very easy to miss. A low sugar episode, loss of consciousness, asymptomatic hypoglycemia. If you're new here, one of the main reasons why I started this channel was to talk about insulin resistance, but also about something much more personal to me. The root cause of my insulin resistance is an insulinoma, but mine doesn't behave like the insulinoma you typically read about. I have a reactive insulinoma, meaning my problems happen in response to eating rather than during prolonged fasting. And that's important because reactive insulinomas are rarer than your typical insulinoma. They're not well understood and they can be very easy to miss. Over the years, I've gone digging through the medical literature looking for other patients whose insulinomas behave this way. And they're out there. There are documented published cases going back decades of people with insulinomas who presented with postprandial or reactive hypoglycemia. So I thought we'd do something a little different on this channel. We're going to have an Insulinoma story time. I'm going to take some of these published case reports, and instead of just throwing a research paper and a bunch of medical terminology at you, I'm going to tell you the patient's story. What happened to them? What their symptoms look like? How long it took to figure out what was wrong? What their testing showed? How their tumor was eventually found? And what happened afterwards, because I think these stories deserve to be known. And today we're starting with a fascinating case out of Japan involving a 71-year-old woman whose insulinoma didn't exactly follow the rulebook. So this case is called Insulinoma Presenting with Reactive Hypoglycemia, Evaluating the Effect of Tumor Resection via Continuous Glucose Monitoring. So a continuous glucose monitor is a little wearable that can tell you sugar levels without having to prick your finger a million times a day. I have one myself. It's right here on my thigh. It's where I like to wear mine. And so in this case, they use the CGM to help diagnose the patients and to monitor them. The date of this was 2017, September 25. So September 25th, 2017 is when this case was published. A 71-year-old woman previously diagnosed with reactive hypoglycemia, so that is where when you eat, a couple hours later you have a low sugar episode, was transferred to our emergency unit because of loss of consciousness. Her plasma glucose level was 27. Anything under 55 is a medical emergency. Whether you have symptoms or not, 55 and lower is not good. Above that, 60 and higher, you're okay. But 55 and lower, regardless of whether you have symptoms or not, is bad. And hers was 27, which is crazy. And the continuous glucose monitoring CGM revealed postprandial asymptomatic hypoglycemia. This is an important thing. I need to make another video on this. Asymptomatic hypoglycemia. There are a lot of doctors out there that talk about it. It's not dangerous if you don't have symptoms. If you have symptoms, then it's dangerous. And that is not correct. Hypoglycemia at 55 or lower is dangerous whether you have symptoms or not, because you can just pass out. She had asymptomatic hypoglycemia, so she had no warning signs that her sugar was going low. Even though she had the CGM, she passed out. Which is one of the good things about a CGM is it can alarm you if you're going low, but it might have gone faster than she could do anything about and she passed out. So she had no symptoms. You can have dangerous hypoglycemia and have no symptoms. This is something that I really want to fight hard against, because there are many doctors preaching out there that if you have low sugars but no symptoms, you're totally fine, and that is not true. It's very, very dangerous information. A hypervascular tumor was identified via computer tomography. So you did a CT scan in the distal pancreas, on the back, the tail of the pancreas. And the diagnosis of insulinoma was confirmed using a selective arterial calcium stimulation test. So they have several different ways to locate an insulinoma. Insulinomas are hard to see on scans. And so they'll use CT, they'll use MRIs, they'll use PET scan, endoscopic ultrasound. And one of the more invasive tests that they'll do later, if they have to, is called a selective arterial calcium stimulation test. And it's a little bit invasive, but it basically pokes the bear to see where the crazy insulin is coming from. So they can see what area of the pancreas. And I've had this test done twice. Although no episodes of hypoglycemia were observed during CGM after resection, a pathological examination identified regional lymph node metastases. It is important to consider insulinoma as a cause of postprandial hypoglycemia, and a CGM is useful for evaluating their treatment outcomes. So CGM is helpful for helping to see where your sugars are before and even afterwards, to monitor to see if you have any more hypoglycemic episodes. And she didn't. Even though they did find that she had metastases to one of her regional lymph nodes, she did not have any more hypoglycemia, which was great. Let's see, introduction. An insulinoma is a rare tumor of the pancreas with an annual incidence of 4 per 1 million population per year. A lot of papers will say this. My personal opinion is that it's a lot more common than that. It's still a rare tumor, but I believe that is a lot more common, but it gets missed a lot. Like with my tumor, I've had my symptoms since 1998, and I still have the tumor inside of me. So it's been a long road of being misdiagnosed and mistreated. And a lot of patients go through this. And we'll see that in this story as well. Since more than 80% of patients with insulinoma demonstrate fasting hypoglycemia, it is difficult to distinguish insulinoma from reactive hypoglycemia if patients only have postprandial hypoglycemia. So a lot of people, even in this paper, they treat reactive hypoglycemia like a disease or like a condition. It is not a condition. You don't get diagnosed with reactive hypoglycemia, just like you don't get diagnosed with itching. Itching is a symptom. It's a symptom of something. Reactive hypoglycemia is a symptom of something. It is not a condition. There is a root cause to it. And the root cause is usually high insulin. Reactive hypoglycemia does not just happen in insulinoma patients. It happens in anyone who has really high insulin levels. So anyone who has insulin resistance has a high insulin levels, and they will experience reactive hypoglycemia and not even know it. You know that mid-morning crash where you feel like you need to eat something or grab some caffeine or something? That's most likely reactive hypoglycemia. 2 to 3 o'clock in the afternoon, same thing, crash. Or after you eat, you feel like you have to take a nap because you just can't function. That's reactive hypoglycemia. It could be postprandial syndrome. I'm going off on a tangent right now. Postprandial syndrome is where you have all the symptoms of reactive hypoglycemia, but without the actual low sugars. Reactive hypoglycemia includes having low sugars below 70. So here they're trying to distinguish an insulinoma from reactive hypoglycemia. It's like trying to distinguish itching from an allergy, from a skin allergy. The skin allergy is causing the itching. The insulinoma is causing the reactive hypoglycemia. So it's the high insulin that's causing the reactive hypoglycemia. So they said it is difficult to distinguish insulinoma from reactive hypoglycemia if patients only have postprandial hypoglycemia. Furthermore, patients with recurrent hypoglycemia may be unaware of the condition. The hypo-unawareness, something a lot of doctors don't understand, that you can be totally unaware that you have hypoglycemia. I have this. My sugar will be low and I'll have no idea. If it isn't for the CGM telling me that I'm low, I would have no idea. I feel great. I feel terrible on the way up. When the sugar is going up, I feel like I can't function, like I have to sleep, like my vision gets blurry and it's double vision, my heart starts palpitating, and I get all these symptoms of hypoglycemia, but when I check my sugar level, it's good. It's 100 to 120 or whatever. But when I'm actually low in the 50s, no symptoms at all. I feel great. And that's usually because your adrenaline is kicking in, so it makes you feel awake and alive and it makes you feel good. So, let's see here. Furthermore, patients with recurrent hypoglycemia may be unaware of the condition, making it more difficult to diagnose the disease. There have been some reports of patients with insulinoma wherein continuous glucose monitoring, so CGM, was used for a diagnosis and throughout the resection process. However, there have been no case reports of insulinoma manifesting as postprandial hypoglycemia in which CGM was used throughout the diagnosis before and after tumor resection. We hear and report a case of an insulinoma with regional lymph node metastases in a patient previously diagnosed with reactive hypoglycemia due to the presence of postprandial hypoglycemia. So reactive hypoglycemia, postprandial, it's the same thing. It's the same symptom. CGM suitably reflected the effects of surgical resection in this place. So they could see that it showed on the CGM that she was having massive lows after eating. And then after her surgery, all her lows went away and her sugar levels were normal. So here's the case report. A 71-year-old woman had struggled for 5 years with frequent episodes of dizziness and anxiety, which usually occurred 1 hour after a meal and were resolved with the intake of sugary food. She had neither diabetes nor a history of gastrectomy. Her body mass index was 26.7. When she was 66 years old, a 75-gram oral glucose tolerance test was performed in the clinic. In this test, her fasting 2-hour and 3-hour plasma glucose levels were 83, 89, and 63 respectively. Based on a rapid and hyper-responsive insulin secretion, she was diagnosed with reactive hypoglycemia. It's not a diagnosis, it's a symptom. She was then given dietetic advice and prescribed miglytol for the treatment of postprandial hypoglycemia. This makes me upset because I've been through this. I've done with this. So she had, when she was 66 years old, she had a 75-hour glucose tolerance test, and they only looked at her fasting, her 2-hour and 3-hour levels. They didn't look at anything else. They kind of cherry-picked the information, and I'm going to put this on the screen so you can see what I'm talking about. It's backwards here. But when she came in, her sugar was 83 and her insulin was 2.9. Now, for a fasting insulin, should be between 3 to 7. So in that case, it's just a tiny bit low. At 30 minutes, her sugar was 64. So it dropped, and her insulin was 1,098. Now, here's something to understand about insulin. A normal fasting insulin, healthy fasting insulin, should be between 3 and 7. After a meal, insulin should spike to about 40, and that's it. No more than that. Anywhere from 20 something to 40, that's a good range. Hers spiked to 1,098. That is insane. At 60 minutes, so at 1 hour, which they didn't talk about, they said fasting 2 hour and 3 hour. At 60 minutes, her sugar dropped to 54. Her insulin was 188.3. At 90 minutes, her sugar was 57. So anything 55 and lower, so in that range, that's a medical emergency. Her insulin was 65 at the 90-minute mark. At 120 minutes, her sugar was 89. Her insulin was 40. And at 180 minutes, her sugar was 63, and they didn't measure the insulin at that point. So her reactive hypoglycemia kind of recovered on its own a little bit and settled. But what they didn't realize is that at the first hour mark, she had reached 54. The way an insulinoma is diagnosed is that glucose at 55 or lower and insulin at 3 or higher is diagnostic of an insulinoma, hyperinsulinemia. Hyperinsulinemic hypoglycemia is what it's called. So an insulinoma, that's all you need. Sugar at 55 or lower, insulin at 3 or higher. Her sugar was 54 and her insulin was 188. That's way higher than 3. And so she totally met the criteria for an insulinoma. And yet they dismissed it. They didn't even look at that. They looked at the first hour, they looked at the fasting, 83, and then the second hour, which was 89, and the third hour, 63. They didn't look at, it's like they cherry-picked the information. Why? And then this woman suffered for 5 more years because no one paid attention to her entire test. For 5 more years, she suffered. She said she struggled with frequent episodes of dizziness and anxiety, which usually occurred 1 hour after a meal, and then were resolved with sugary food. So she was eating all day long. She would eat, and then she would have a hypoglycemic attack, so she would eat again. And when you eat, and when you have postprandial hypoglycemia or reactive hypoglycemia, every time you eat, you restart the vicious cycle. So she was eating all day long, trying to chase this monster and dealing with dizziness and anxiety, and she just went through hell. This poor woman. I feel so bad for her. So they gave her advice, probably told her to eat 8-10 times a day like they told me, and they gave her some medicine, and it says, however, the frequency of the symptoms did not change. In 5 years after the diagnosis of reactive hypoglycemia, she was transferred to the emergency unit in our hospital because of loss of consciousness. This poor woman could have died. If she was driving, she could have lost consciousness while she was driving. She could have killed somebody else. The negligence in this is insane. Upon arrival, her blood glucose levels, serum insulin and serum C-peptide, were 27, 14.6, and 1.9 respectively. So her glucose was 27, crazy low. Her insulin was 14.6. Remember, for an insulinoma, glucose of 55 or lower and insulin of 3 or higher, her insulin was 4.6. That's several times over the limit of what she needed to have for an insulinoma. So that's absolutely criteria. Those data confirmed hypoglycemia without suppression of insulin secretion and met services criteria, blood glucose under 40. Here's a problem. Their criteria was wrong and very outdated. This is 2017. The criteria from at least 2009 that I've been able to find has been glucose at 55 or lower, insulin at 3 or higher, and then ketones at 2.7 or higher. And so they had the wrong criteria. Because they had the wrong criteria, they made this woman suffer 5 extra years for nothing. They said that the blood glucose had to be under 40, serum insulin above 60, and C-peptide greater than 0.6, which she met that in this situation, but she had to almost die to help them understand that this is what she had. Based on the normal values for serum cortisol level and insulin antibody, so they tested all other stuff and everything else was good. Both adrenal insufficiency and insulin autoimmune syndrome were excluded. She had no other issues. Computed tomography, so CT, revealed a ring-enhancing lesion indicating a hypervascular tumor with a diameter of 18 millimeters. Furthermore, following selective arterial calcium stimulation tests targeting the splenic artery, the serum insulin level rapidly increased from 61 units to over 5,000. So 61 units, it should have been near 5. 3 to 7 is the range. So she was at 61 units when they started this test, and then it went over 5,000. It's not supposed to go over 40. She was making an insane amount of insulin. Confirming the hypervascular lesion seen on CT was an insulinoma. So she got lucky in a way that her CT caught the insulinoma. Most insulinomas are not seen on CTs or MRIs or even PET scans or endoscopic ultrasound. They're really, really hard to see. They're made of the same cells as the rest of the pancreas. They're very slow growing, so they don't have a lot of blood vessels to feed them, and so they don't show up on scans. Let's see, where are we at? Oh, it shows her all her tests, all her blood work. Everything turned out really good. Looking over it myself, yeah, everything looks really good. Except, her HbA1c, even though she had really high glucose level or high insulin levels, her HbA1c was 4.6. She had insulin resistance, even though her fasting insulin was low, and her A1c was 4.3. When I first got diagnosed, my glucose was in the 80s. My A1c was 4.3, so even lower than hers, and my insulin was 12. It's supposed to be around 5, so it was more than double the amount it should have been. And then here is a picture. I'll put these up. You can see the tumor right there at the end of her pancreas. So this thing right here is her pancreas. This is her stomach. This is the liver. You got a kidney and another kidney, and then the spine right here, and these are the back muscles. And this little skinny thing right here, that's the pancreas. Well, and these are the intestines, in case you're wondering. And then these round things, these are like the blood vessels, the main blood vessels that run through your body. So this is the pancreas, and right there at the very end, you see something lighten up. That is the tumor. It's a good size, too. Contrast enhanced computed tomography image of the abdomen. The arrowhead indicates a hypervascular tumor with a diameter of 18 millimeters. When they did the calcium stimulation test, this is the graph where you see most of them were normal, and then this one just went crazy. They're all producing a lot of insulin, way too much insulin than normal, but this one went nuts. So they knew this is the area where the insulin, so basically, if you're looking at this, they would test right here, right here, right here, right here. They would basically poke the different areas, shoot calcium at it to see where it would respond with a massive amount of insulin. And the area that has the most insulin production, that's the area where the tumor is at. So this is her graph there explaining that. This says insulin secretion responses after selective arterial calcium stimulation test. 7 days after the diagnosis by the calcium stimulation test, she underwent laparoscopic resection of the distal pancreatic lesion. A pathological examination revealed that the tumor size was 25 millimeters by 23 millimeters by 13 millimeters. So they saw 18. And this is something I've noticed in a lot of case studies that I've read. It looks a certain size on a scan, and it'll usually be bigger when they actually cut the whole thing out. So some of it, the edges of it, you can't really see on scans very well. So they end up usually being bigger than what they initially see. The tumor was neuroendocrine, so insulinomas are neuroendocrine tumors, well differentiated and stain positive for synaptocystin, I say it wrong, insulin and chromogranin. Histological features compatible with an insulinoma, although the Ki-67 index of the tumor was 1.0, so it was basically a benign tumor, but they did have a single regional lymph node metastasis, so it's not necessarily benign, even though it behaved like a benign tumor, except for that one metastases. Located under the pancreas lymph node was identified. Neither recurrence nor distant metastases were detected by CT or somatostatin receptor octreotide scintigraphy conducted 3 to 5 months after surgery. So after her surgery, she had more scans done to see if there was anything left behind that they possibly could have missed. And she had no more hypoglycemia and no scans that they could, nothing picked up anything on the scans. This, I should probably do a, what is it called? Trigger warning. This is the tumor. If you don't want to see it, look away. That is the tumor. The yellow stuff, I think, is part of the pancreas. Let's see here. 7, 8. Okay. Pathological examination of the pancreatic tumor. So this one right here is basically what they see under the microscope. We can't tell what that is, but pathologists can. In this case, CGM was performed throughout the diagnosis. So she had her CGM on before she went in the hospital, during her hospital stay, after the surgery, before and after the tumor resection for a total of 14 days during her hospitalization. Before surgery, her blood glucose levels were about 81 with 16 or up and down deviation, and dropped below 70 22 times in 7 days. So in the 7 days that they had her in the hospital, she dropped below 70 22 times. So she had set 22 hypoglycemic episodes, even with continuous intravenous glucose administration. So even though they were feeding her glucose through the IV, she was still having the drops. Many of the episodes of hypoglycemia were asymptomatic, meaning she had no symptoms. Without the CGM, she would have not known that she was even low. And 50% of the total hypoglycemic episodes happened postprandially or after rapid glucose infusion. So most of her episodes were after she had just eaten, or if she was given a rapid glucose infusion instead of like a slow drip, indicating reactive hypoglycemia on CGM. It's a symptom, not a condition. After surgery, CGM revealed blood glucose levels of 123 plus or minus 23 and no hypoglycemia. So after surgery, it's very common for your sugar levels to stay a little higher, because when you go through something as traumatic as surgery, your body releases more sugar to deal with the stress. So that extra stress on the body is going to keep your sugar levels higher. I can pretty much bet that after she recovered from surgery, her sugar levels dropped to a more normal range. But after surgery, it is very common to see higher than normal glucose levels. And hers were 123 plus or minus 23 points. And no hypoglycemia under 70, findings that were consistent with the surgical cure of insulinoma. So they fixed her. These data suggest that the CGM is useful for evaluating the treatment outcome of insulinoma. This patient did not complain of further hypoglycemic symptoms during the subsequent 6-month follow-up period. When it's time for me to get my tumor removed, I'm going to have the same thing. I'm going to try to keep my CGM on as long as possible. And these are her graphs. This is the before her surgery. It's like that's like eating or a rapid glucose infusion. And you can see all the different times that she dropped below, had hypoglycemic episodes. So that's 70. So anything that was under 70, these are all hypoglycemic episodes. And then you see this one. This is where 70 is at. Look at all this. Her sugar level stayed above 120, 100 the whole time pretty much. So it stayed stable. She had no more hypoglycemic episodes. Let's see, which page is this? That's 9. That's 10. All right, so while there have been some reports of insulinomas in which CGM was used for diagnosis and during the resection process, our case is the first report of insulinoma presenting with postprandial hypoglycemia, in which glucose fluctuation was monitored via CGM throughout the diagnosis and management before and after tumor resection. Major causes of postprandial hypoglycemia are gastric surgery. So people who have had gastric bypass will experience reactive hypoglycemia, but it's a little different than this. It's not because of a high insulin production from a tumor or from your body having too much insulin due to insulin resistance. With gastric surgery, there's a mechanical piece. There's nerves that have been cut that cause dumping syndrome and cause the stomach to not be able to hold on to the food properly enough to digest it, and it just dumps into the intestines, causing dumping syndrome, which then causes reactive hypoglycemia because your sugar goes up and then your insulin responds really fast, and then it causes a fast drop. So major causes of postprandial hypoglycemia are gastric surgery, reactive hypoglycemia due to hyperinsulinemia in insulin-resistant subjects. So that's the one time they got that right. Reactive hypoglycemia as a symptom due to hyperinsulinemia, too much insulin, in insulin-resistant subjects. You will never find someone that is insulin-resistant without having high insulin. Those two absolutely go together. You'll never find them separated. If you have high insulin, you have insulin resistance. If you have insulin resistance, you have high insulin. Full stop. And pancreatogenic hypoglycemia such as nocidioblastosis. So there's a condition called nocidioblastosis where the beta cells that make insulin, they're bigger than normal. And the bigger they are, the more insulin they produce. And that causes a higher insulin output. Too much insulin will cause low sugars. There's also one more, which I don't think they mentioned. It's called NIFS. NIPHS, or beta cell hyperplasia. That's where you have more than the normal amount of beta cells. So beta cells are the cells in your pancreas that make insulin and help keep your sugar normal. If you have too many beta cells and then you bring in glucose and they over-respond because there's an over-response of insulin because there's more beta cells than normal. So that is called beta cell hyperplasia. And they don't mention that in here, but that is one of them. Our patient was not obese and did not have a history of diabetes, gastrectomy, or gastric bypass. So she did not have gastric bypass. She didn't have high sugar levels, and none of that. Furthermore, insulin autoimmune syndrome was excluded. So they did a blood test for insulin autoimmune. She did not have that, as a serum insulin autoantibody levels were undetectable. Although the typical symptom of insulinoma is fasting hypoglycemia, a retrospective review indicated that 27% of patients with insulinoma displayed postprandial hypoglycemia. 27%. Our case illustrates the importance of considering an insulinoma as a cause of postprandial hypoglycemia. Very little is known about why some insulinomas cause postprandial hypoglycemia. I'm going to do another video on this, but reactive insulinomas, or insulinomas presenting with postprandial hypoglycemia, have been around since the 1930s. Okay, they're just not put in textbooks, so doctors don't ever learn about them. But they've been around almost 100 years. Insulinomas were first coined in 1926, and in the 1930s, reactive insulinomas were discussed in medical literature. But it's never put in medical textbooks. I have some medical textbooks, and it's not. You have like 1 or 2 lines about insulinomas there, and there's nothing about reactive hypoglycemia or reactive insulinoma or an insulinoma with postprandial hypoglycemia. So that's one of my goals in my life and on this channel, is to bring awareness to these reactive insulinomas. A previous report noted an increase in frequency of postprandial hypoglycemia reported in cases of insulinoma over time, from 2% 1987 to 1992 to 10% 2003 to 2007. It's because there's more awareness, there's more people talking about it, there's more case studies. This is one of the reasons why I want to do this, because there are so many people that get missed. Look at me. From 1998 till now, I'm still dealing with this. I'm about to go to the Netherlands next month for a scan for this tumor because it's so hard to see. Insulinomas are known to be really hard to see. Let's see here. Those data led us to speculate that environmental factors and changes in dietary habits over time might be responsible for the increased frequency of postprandial hypoglycemia. Or we just missed it because anytime somebody had reactive hypoglycemia and didn't have regular hypoglycemia, they were dismissed. Furthermore, some reports have suggested that diversity in the glucose transporter might contribute to the mechanism of postprandial hypoglycemia and insulinoma. Actually, they found out, and they don't talk about this in this study, but they're finding out that insulinomas have more GLP-1 receptors. And so when the more GLP-1 receptors they have, anytime you eat, you spike GLP-1, and that GLP-1 tells beta cells to release insulin. And if a tumor has a lot of GLP-1 receptors, then that GLP-1 is really going to trigger that production of insulin. And so the more receptors you have, the more response you get. So that makes total sense. Where did I go? While insulinoma cells usually express GLUT1, the original pancreatic B cells normally express GLUT2. However, in patients presenting with postprandial hypoglycemia, the expression of GLUT2 in the tumor cells might increase, leading to an excessive insulin secretion after glucose intake. So, of course, this was 9 years ago. They didn't really know that much about GLP-1. That's still kind of an ongoing thing now with the GLP-1. Some patients with insulinoma, including our patient, are unaware of their hypoglycemia as a result of recurrent hypoglycemia. In such cases, CGM is useful for detecting hypoglycemic events leading to a diagnosis. Interestingly, our CGM analysis detected asymptomatic hypoglycemia after meals, even after rapid intravenous glucose infusion. So, their normal treatment when you have low sugar is to give more sugar. But in a reactive hypoglycemia situation, more sugar just restarts the vicious cycle. I did a 72-hour fasting test for my insulinoma, and what I learned is that when I fast, I'm great. My glucose levels are great. It's when I eat that the problems start. And if you're constantly treating a low with food in a reactive situation, you're going to keep yourself on this perpetual cycle and you'll never get off of it. I'm very, very thankful for my 72-hour fast because it helped me to learn that my body can take care of itself. And if I manage the response, I've changed my diet to manage the response of the tumor. I can keep the insulin from spiking as high from my tumor by changing how I eat. And I'll talk about that in another video. Let's see where we are. So some patients with insulinoma, including our patients, okay, we read that. Therefore, intravenous glucose should be administered carefully in patients with insulinoma to prevent reactive hypoglycemia. Duh. Yes. Do not give sugar to a reactive hypoglycemic unless they have regular hypoglycemia alongside. And that does happen. You can have both types of hypoglycemia where you can have reactive hypoglycemia but have an inability to raise your own sugar levels, where you have either pituitary insufficiency or adrenal insufficiency or glucagon deficiency or pancreatitis or something, where you can have something else that keeps you. Oh, glycogen storage disease is another one. If you have glycogen storage disease, you're not going to be able to access the glycogen to keep your sugar level up in response to a reactive event. So in those cases, yes, you get to 55 or lower. If your body can't recover on its own, you need to treat. But if you treat with fast sugar, you're going to put yourself on this virtual roller coaster of doom. Okay. Insulinoma is classified as a neuroendocrine tumor by the WHO criteria revised in 2010. In our case, tumor cells were well differentiated, which is supposed to be a good thing, and the cell proliferation rate was low. Ooh, that's a mouthful. So it wasn't growing fast. Insulinomas are known to grow extremely slowly. An average, a centimeter grows in an average of 10 to 15 years. So hers was it 25 millimeters? So hers has been growing for probably a couple decades, and she did not know. Let's see here. Her growth rate was low, but a regional lymph node metastasis was detected. The incidence of malignant insulinoma is only 5 to 15%, and malignant insulinoma with postprandial hypoglycemia has never been reported, or so they think. Thus far, the tumor morphology of insulinoma has not been useful for predicting the pattern of hypoglycemia, fasting or postprandial. Although the clinical prognosis can be estimated well based on the rate of the tumor cell proliferation evaluated by mitotic count and Ki-67 staining. So the tumor didn't grow very fast. In addition, tumor size may affect the magnitude of insulin secretion. So the bigger the tumor is, the more it can secrete, which is why her insulin levels were crazy through the roof. Although the distant metastasis lesion was not detected by CT scan or SRS in the present case, follow-up examinations are important for detecting or ruling out tumor reoccurrence, since the clinical course of well-differentiated insulinoma with a metastatic lesion can be highly variable. So you never know. It seemed like she got cured, but it's good to keep checking just in case, especially if they feel like they found that it spread. They want to keep checking to make sure. As a limitation of the study, there are conflicting data about the accuracy of CGM at low glucose levels. For instance, the euglycemic hyperinsulinemic clamp study showed that interstitial glucose concentrations could fall even when plasma glucose levels remained unchanged. So that is the thing with CGMs. CGMs are not completely accurate. They are very useful for trends. They help in cases with hypoglycemia unaware, but they are not perfect, and sometimes they are off. And sometimes you'll have a low on a CGM that is not a real low. And that happened to me this morning. I was in the kitchen cutting food up for my cats, and my CGM said I was at 54, and I did a finger stick, and my sugar was 89. So there was something wrong with the CGM. And that happens sometimes. So you can't just take CGM readings at face value. You have to take them with a grain of salt. They're not going to be perfect. You want to have a finger stick monitor to always check and see if it's accurate. Let me see here. Conversely, sensor glucose levels might remain lower than plasma glucose levels during mild hypoglycemia and recovery from hypoglycemia. More accurate glucose sensors are needed for next generation CGM in the near future. Of course, this was 2017. So all the sensors back then weren't as great. I think, was it 2016 was when I had my first CGM. It was a Dexcom 4. What I like about the new Dexcoms, that's what I have right now, this Dexcom G7 15-day, is that you can calibrate them. After the first 24 hours, you can't trust it. It'll read really low or really high or whatever. It's going to be wonky all over the place. So I'll put it on and not even scan it for at least 12 hours or sometimes the full 24 hours. It's recording the data, but I'm not going to have it on my phone because my phone will sit there and alarm me in the middle of the night, oh, you're having a low, when you're not having a low. And then that's going to disrupt my sleep, and that's going to be a problem. So the first 24 hours, I ignore it. But then afterwards, I calibrate it, and I use a finger stick monitor. And once it's calibrated, it stays pretty good, except for the few occasions where I'm standing. I found out this is a kind of a weird thing. And I don't know if this is happening to anybody else, but if I'm just standing in the kitchen doing dishes or just standing in place and not moving around much, my CGM will start to read low, even though I'm not actually low. I'll test with a finger stick and my sugar is normal, but my CGM will read low until I sit down. So not sure what that deal is, but there is something there. Eventually I'll figure that out. Where are we at? In conclusion, it is important to consider insulinoma as a cause of postprandial hypoglycemia. Yes, CGM is useful not only for the detection of asymptomatic hypoglycemic events, including reactive hypoglycemia, but also for the evaluation of the treatment outcome, to kind of keep track of the patient, see how they're doing, so they're not pricking their finger every hour. Because especially if they have no symptoms, you have no idea if they're going low or not. And so that's why having a CGM is just, it's a blessing. It's not perfect, but it is a blessing. And then there's a bunch of, what do you call them? And that's it. This is the Insulinoma story of the day. I hope you learned something from it and understood that, especially if you are a doctor, or if you are a patient that is dealing with reactive hypoglycemia and think you may have an insulinoma, and doctors have told you that, oh no, they don't exist, they're only with fasting hypoglycemia. If you don't have fasting hypoglycemia, you don't have... The link is going to be in the show notes. Go find it, print it out, and give it to your doctor so they can understand that reactive insulinomas do exist, and one of the best tests for a reactive insulinoma is the glucose tolerance test, because it's reactive hypoglycemia, it's not a fasting test. So an extended oral glucose tolerance test, you want it to be minimum of 3 hours, but 3 hours might not be enough. 5 hours. 5 hours where they check sugar and insulin. They should be checking C-peptide and proinsulin at the same time. The reason why proinsulin is there's such a thing as a proinsulinoma. It's like an insulinoma, but a little bit different. Your insulin levels can be normal and you can have high proinsulin, and that would be a proinsulinoma. And it's very similar symptoms. So you want to check those 4 things every single hour. So it's a total of 6 sticks. You come in fasting, they check to see what your levels are. Then they give you this glucose drink, you down it in 5 minutes, and then they start the clock. And then every hour on the hour, they do a blood draw, and they check all your levels. And within 5 hours, they'll know several things: how high your sugar went, how low your sugar went, how high your insulin went. And then if you had a hypoglycemic episode of sugar 55 or lower, if your insulin was 3 or higher at that same time, then that proves hyperinsulinemic hypoglycemia, which could be either from an insulinoma, nesidioblastosis, or beta cell hyperplasia, one of those 3. And it also will show you very important information. It'll show you if you can recover from a hypoglycemic event. That makes a huge amount of difference, because if you can recover on your own, that keeps you from having to down a bunch of sugar to bring your sugar levels back up. Your body can handle it on its own. That'll tell you that you can handle it on your own. You don't have to freak out and try to drink orange juice and eat a bunch of stuff that will just restart the vicious cycle. And that's what I learned when I did the 72-hour fast and found out that I could fast the whole entire time and feel great. My sugar levels stayed above 70 the whole time. That helped me to understand that I did not have regular hypoglycemia. And then when I did the glucose tolerance test and saw that my blood sugar recovered, came back to the 70s and 80s when it was done, then that showed me that I didn't have to worry about, oh, I need to eat or else I'm going to die. So with reactive hypoglycemia, as long as you don't have regular hypoglycemia alongside it, your body should be able to recover. So this is the important information that you'll get from an extended oral glucose tolerance test. I hope this information helped. If you have any questions, please leave them down below, and I would love to get to them. Thank you for watching this session of the Insulinoma Story Time, and I'll see you guys for the next one.